All right, well, I want to welcome everybody. My name is Dr. Gary Kaplan. I'm Medical Director of the Kaplan Center for Integrative Medicine, and we sponsor this series on what is being referred to as total recovery, solving the mystery of chronic pain and depression. But it also is applicable to virtually all neuropsychiatric diseases. One of our approaches, and one of the things we've been dealing with at the center for many, many years, because we see lots of people with chronic illness. We see people with chronic fatigue syndrome. We see people with fibromyalgia. We see people with virtually any and all musculoskeletal pain problems, herniated disc, people with migraines, people who are very frequently also suffering with comorbid neuropsychiatric diseases, depression, anxiety disorders, post-traumatic stress syndrome. And in fact, that overlap constitutes about 65% of our population. And we've been struggling with this, as indeed most of the chronic pain profession has been struggling with this for decades, because there's a couple of things that off the bat that both pain and depression have in common. And that's that you tell us about it and we believe you. Because for the most part, there's very little objective evidence to justify what it is going on. We can't measure depression objectively. We can't measure pain objectively. All right? We have people who come in, and one of the things that always fascinated me was we have people come in with really severe osteoarthritis, okay, on x-ray. No discomfort whatsoever. They were coming in for a physical. We have people who come in with next to no changes on x-ray, and they're in excruciating pain. They can barely move an arm or a shoulder. Sometimes you can attribute it to tendinitis, but other times, in cases like fibromyalgia, you've got these generalized pain syndromes where they hurt everywhere. But what's the cause? And so we've been doing a lot of research. I particularly have been spending a lot of time trying to understand what this was about. And over the years, we put together a panel of physicians who were meeting on a quarterly basis. Several psychiatrists, one from NIH, one of the neurophysiologists from Georgetown, and we've been trying to understand what's been going on with this. Why is there so much overlap between the psychiatric profession and the chronic pain field, which is what we come out of, and why are we struggling with these conditions and having such, frankly, abysmal results? And over time, what started to emerge was this concept that, in fact, these diseases are not what we thought they were to begin with. That maybe we've been thinking about them all wrong. That maybe there's a common physiology to these diseases, and that's why we see so much overlap. And indeed, there is a common physiology. Both of these diseases are neuroinflammatory, neurodegenerative, and fortunately reversible if we understand that they're neuroinflammatory. Now, thinking about these diseases as neuroinflammatory diseases changes the whole field, because now all of a sudden we can look at people and say, you know, you're depressed, okay, but is this nothing more than a manifestation of some other cause of a chronic neuroinflammatory condition? Or is your pain a result of some inflammation that's going on in the central nervous system as a consequence of Lyme disease, as a consequence of psychological traumas? And so this whole business of beginning to review this as a neurophysiologic inflammatory process changed the way we started treating people and changed the results we were getting, more importantly. So at the basis of this is a little guy called a microglia, as it turns out. So as we discovered that there was a problem with neuroinflammation, the question then became, what's causing inflammation in the central nervous system? What causes inflammation in the central nervous system is not a lot of things, but really mostly this little guy right here called a microglia. The microglia is the innate immune system in the central nervous system. So it's essential for keeping the immune system healthy. It fights off bacteria, it fights off viruses, but it does a lot of other things in the next slide. So a lot of things that turn on this guy and keep him activated are ischemia, such as occurs in a stroke, hypoxia, such as occurs with it's low oxygen to the brain, but we see it in sleep apnea. So 5% of the population's got sleep apnea. In medications, so the medications that we were using and have been using over the years to treat these conditions turn out some of them working for us and some of us working against us. So use of narcotics works against us. When you first use narcotics short term, the neurons respond to them because they have more receptors for opioids than the microglia do. But after a couple of weeks, the microglia come into action. And when the microglia get upregulated from the narcotic medications, okay, codeine, morphine, when they get upregulated, the next thing that happens is we start seeing tolerance built to the medication and thus the need for more of the medication. And worse yet is we see hyperalgesia, an increased sensitivity to pain. So now we're fighting against the very thing we thought we were treating. Toxins come in all forms. Mycotoxins from molds, toxins from the environment, from lead. All of these things can upregulate and cause the microglia to move into an inflammatory state in the central nervous system. Neurodegenerative diseases, Alzheimer's, multiple sclerosis, AIDS-related dementia are also all diseases associated with microglial activation, but in those diseases, to date, we don't know how to reverse them, and it looks like it's a dysfunction of the microglia that may be involved in the process, though at one point they thought the microglia itself were responsible for the disease. At this point in time, unclear. Infections, Lyme disease, which we'll be talking about at our next lecture series. We'll have Dr. Sam Shore here. And Epstein-Barr virus. If you want to know what microglial activation looks like, when you get sick with a flu and you have a high fever and you feel crummy all over and your sweats and you can't sleep, that's microglial activation. Okay, that's what it looks like in a really acute upregulated state. In a chronic state, it looks like chronic pain, chronic fatigue syndrome, fibromyalgia, migraines. It's a whole list of things: depression, anxiety disorders, post-traumatic stress syndrome. The other thing, which is one of the things we're going to be focusing on today, although this splits actually into two categories, is trauma. Because the other thing we see that will cause microglial activation is psychological trauma. So people who have been through wars, people who have been in assaults, people who have post-traumatic stress syndrome. The number one cause of post-traumatic stress syndrome is car accidents, in which, in fact, the majority of people following a significant car accident will have post-traumatic stress syndrome symptoms for upwards of a year afterwards. So post-traumatic stress syndrome is one of the things we see. But if you grew up in an alcoholic family where it was complete chaos, where your parents were abusive, these create the psychological stressors that set up the potential for long-term microglial activation. Physical trauma is the other thing, and that's what we'll be focusing on today, is damage to the musculoskeletal system, which is ongoing. And then trying to understand the specifics of that becomes crucial because there's lots of different components as to always the questions, what's the pain generator? And Dr. David will be talking about that at length. Next slide, please, John. So the take-home points that I want to continually drive through this whole lecture series is that this is what's referred to as a central sensitization syndrome, when you have an overlap of pain and any neuropsychiatric disease. But they're on a spectrum, and all of these diseases are neuroinflammatory, neurodysregulatory, and neurodegenerative, which also means that it's really important that we get to them as soon as possible, because as you age, it gets harder and harder to treat these problems. These problems are also cumulative. So the traumas typically are not an event, but rather a series of multiple injuries that people have sustained. And so it's important that we take a very big perspective when we're taking a history, and that gets us the most complete results. The goal being total recovery. Go to the next slide, please. So the etiologies, multitude as we've already gone through. So this is just a list of everything. And you also have to think in terms of metabolic issues such as thyroid disease, autoimmune diseases such as celiac disease. Would you move to the next one, John? And so how do we go about treating this? And the answer is the only way you will be successful at treating this disease process is being in a comprehensive program as you address these things. So you have to address all of the underlying problems if you're suffering with post-traumatic stress syndrome. Example, a young woman came in to see me in her 30s. She had been in a car accident when she was 18 years old and sustained a whiplash injury, a mild concussion. Over the next couple of years, her condition evolves in what's called fibromyalgia, generalized pain syndrome. All right? Treatment after treatment after treatment, nothing is working on her. Now, I don't believe that that event is what caused the problem. I believe that was the tipping point. So now we push back in her history, and what else is there? In her case, what else was there was when she was 12 years old, she was raped. and she has post-traumatic stress syndrome. Not simply because she was raped, she has post-traumatic stress syndrome because she is in tears and shaking and crying while she's telling me the story, because she hasn't told anyone else. It's been a secret that she's held all these years. Now we know we have to get to this component that's keeping the system inflamed in order to resolve the rest of it. And as we've done so, she in fact is recovering nicely. But we have to address both. The pain's not imaginary, the pain's not pretend, the damage to her neck wasn't make-believe, it had to be addressed. But without addressing the psychological component, that was because what we're looking at is manifestations of a neuroinflammatory disease, we don't get a complete result. When we do all of it, then we get total recovery. So medications, and there are different medications that we can utilize, prolotherapy, regenerative medicine, which we're going to be talking about tonight, nutrition, sleep, acupuncture. We talked about meditation last time. Jonathan Faust gave a really spectacular lecture on that that's available on the website, and you can simply go to www.kaplanclinic.com, and we've got all the lecture series posted there so you can view them anytime you want. Psychotherapy, acupuncture, all of these things become part of the process. And as the lecture series continues, we'll be going on in detail about all of these approaches, but also all of the things that can create the problem. Tonight, we have the privilege of having Dr. David Wang. David is a dear friend, and I've known David since before he went to medical school. David attended the osteopathic school in West Virginia, and then went from there to Harvard, Spalding, to do a residency in physical medicine and rehab. David has over time become one of the nationally known, internationally known experts in prolotherapy and regenerative medicine. And he lectures internationally. He gives several weeks of his a year of free time to help teach other physicians how to do prolotherapy in Mexico and down in Honduras, and treating an underserved population down in there. And it's a privilege to be able to both work with David and have him here this evening, and I think you'll thoroughly enjoy the show. So thank you, and I give you Dr. David Wang.
All right, thank you very much, Dr. Gary, for that delightful introduction. And I love the fact that we can now look at how we can integrate what I'm going to be talking about in the care of the entire person. And that really is what it's all about, taking care of the entirety of a human being, of what makes you who you are. And so I'm just going to be taking one small facet of what that is, but it is an interesting facet in terms of the developments over time of how we can get people to heal themselves optimally. The focus of the regenerative therapies is for basically joint, tendon, and ligament pain, and so I'm going to be going into a little bit of detail about what entails pain coming from those sources in the body. So, next slide, please. All right, so actually, Dr. Gary did a fantastic job kind of going over what we do over at the Kaplan Center, but in a nutshell, it is the longest established integrative medicine clinic in the metro D.C. area. We specialize in the treatment of pain, although we handle a lot of different things in addition to just treating pain. And it truly is an integrative approach in that we have multiple folks with multiple areas of specialty who work all under the same roof. So we have medical, we have nursing, laboratory, physical therapy, massage and craniosacral therapy, acupuncture, nutrition, psychology, you name it, we got it. So it's kind of a one-stop shop there. Next slide, please. All right, and so in terms of my role there, so the Kaplan Center has a collaboration with PMR Center. So what the heck is PMR Center? So it's kind of the umbrella group that I work with in terms of the regenerative medicine side of things. And so PMR Center basically stands for Performance and Musculoskeletal Regeneration Center. So we have a collaboration with Dr. Gary and the group there. And we focus a lot on the use of diagnostic musculoskeletal ultrasound, which is that fine machine over there, when necessary, which really helps us to be able to see exactly what's going on a from a structural standpoint, as well as providing the regenerative therapies, which of course we'll go into in a lot more detail. But those regenerative therapies, by name and anyhow, include prolotherapy, platelet-rich plasma, and autologous stem cell therapies. And so we'll be going into the definition of what exactly those things are in a few more minutes. Next slide. A little bit about myself. Really, Dr. Gary went over most of this, if not all of it. Actually, I think all of it. Yeah, so, all right, moving on. Actually, one interesting thing is just last week I got back from one of our prolotherapy medical missions, the one in Mexico. So every January I go to Mexico, every March I go to Honduras, and I think we broke a record this year. So we did I think 1,173 treatments in 4.5 days. There were 17 physicians and a support group of 85 volunteers from one of the local churches down in Guadalajara, which is headed up by Dr. David de la Mora, who's our main physician contact down there. And let me tell you, it is just an amazing experience having a chance to really provide this care for folks that wouldn't otherwise really have good access to medical care. It's pretty phenomenal. So I feel very lucky to be able to be a part of that. Anyhow, so moving on to joint pain and injury. So we're going to be talking about joints first, and then we're going to be talking about ligaments and tendons. All right, so sources of pain that are within the joint. So anyone who suffers from joint pain, and you've seen a doctor for it, you've probably heard some of these little catch terms here in terms of, well, synovium is not as well known, but a lot of people that have, for example, like rheumatoid arthritis or lupus or that sort of thing, a lot of times that affects the synovium, which is basically the inner lining of the joint there. You've got a capsule to the joint here, and then bursal lining. A lot of people hear about bursitis. You've got the meniscus in the knee, the labrum in the hip and the shoulder, the discs in the spine, but you also have a disc in the jaw, and you have a disc in the wrist as well, and they all behave kind of similarly when you have damage to that disc. And interestingly, when people talk about arthritis, so when people think about arthritis, they think about an x-ray that looks horrible, right? And so you think, okay, well, x-rays show bones, and so arthritis means that the bone is not doing well. But in reality, arthritis, by definition, is a degenerative process of the cartilage. So the cartilage being the smooth lining on the bones within a joint. Now, what's interesting, though, is that cartilage actually doesn't have any pain fibers in it. All it is basically a low friction surface to allow for the smooth movement of joints. And so even though the cartilage can be quite degenerated, a lot of times people do not have pain, which Dr. Gary alluded to, how actually the majority of people that have arthritis in various joints don't actually have pain in those joints. And so where does that pain come from? Well, it comes from one or more of these other things, with the synovium and the articular capsule really being an area where a lot of people who have symptomatic arthritis, that's where their pain is coming from. It's not coming from the bone, it's not coming from the cartilage. Next slide, please. All right, so now we're going to talk about tendon and ligament injury. So this is a remarkably underappreciated area in terms of where pain and dysfunction and loss of livelihood can come from. So there was a study that was done back in 2008 that estimated that of the greater than 100 million musculoskeletal injuries that occur around the world every year, 30 to 50% of them are from tendon and ligament injuries. So that represents many tens of millions of injuries per year, every year. So it's a big problem. And this is one example here of a ligament in the spine here, which you can sprain if you lift inappropriately. So a lot of people talk about good lifting technique. Interestingly, good lifting technique has nothing to do with your discs, which a lot of doctors will tell you, oh, well, if you don't lift correctly, you can herniate a disc. That's actually not true. What you can do is you can sprain a ligament, and ligaments can cause a whole lot of pain. All right, next slide, please. Okay, so what the heck is a tendon? So a tendon is a structure that attaches the muscle to the bone. And when you have a strain injury, that means, or a strain as opposed to a sprain, and I'll describe the difference. Actually, there really isn't much of a difference there, but a strain is an injury to a tendon or a muscle, basically just like a stretch injury, which can lead to a tear in some cases. A lot of people have heard of tendinitis. So by definition, tendinitis is inflammation of the tendon. Now what's interesting is, since 1976, we've known that if an injury is more than an injury to a tendon is more than 3 or 4 weeks old, it is not tendinitis anymore. It is not inflammatory. Instead, it becomes this thing called tendinosis. So what the heck is tendinosis? Well, tendinosis, by medical definition, is chronic degeneration. And there is actually a lack of inflammatory cells when you look at these things under a microscope. So I don't like to use this term, chronic degeneration, because when I say, oh, well, you have a tendon that's chronically degenerated, people kind of freak out and they think, because when you think of the term degeneration, you think of this process where whatever it is that's degenerating, like, keeps getting worse and worse and worse and worse over time until there's nothing left. But from a medical definition standpoint, that's not actually the case. Chronic degeneration just basically means it's been around for a while. Just means it's now chronic. It's not acute, and that doesn't mean it's going to get any worse. but it also means that it's probably not going to get better either. It just sort of sits there. And so tendinosis is actually a more accurate term for any tendon injury that's been around for basically more than a month. Tendinopathy is a term that we use which represents any painful disorder of the tendon. So if we don't take a little microscopic look at it and we can't see that it is in fact tendinosis, we just call it tendinopathy. So when you look at the medical literature these days, they talk a lot about tendinopathy. So you may see that word a lot. And basically it just means any injury, any painful condition of the tendon. All right, so a ligament. A ligament attaches bone to bone. So whereas a tendon attaches muscle to bone, a ligament attaches bone to bone. But when you look at these things under a microscope, they actually look very, very similar. And so in the slides over here, we see healthy tendon and ligament tissue. And in here we see chronically degenerated tissue where it has all these little black dots. And those black dots are basically fibroblasts, which are cells that are attempting to heal the tissue. But because they don't have there isn't a very good nutrition supply because of poor blood flow, those cells aren't able to fully repair the tendon or ligament. Here's a slide where you see the transfer of the, in this case, tendon into bone. And there's like this little watermark, as they call it, or a tide mark line where basically things become calcified, and then that's where it attaches to the bone. And this is going to become important in terms of when I discuss treatment technique for these types of disorders. So anyway, a sprain is basically an injury to a ligament, whereas a strain is injury to a tendon. Next slide, please. All right, so what are some common injuries to ligaments and tendons? So a lot of folks have probably heard of these conditions here. So rotator cuff injuries, tennis elbow, jumper's knee, Achilles tendonitis, plantar fasciitis. So again, by the word, tendonitis means inflammation or an acute inflammation of that Achilles tendon in the back of the heel here. But in reality, most cases are actually chronic, so they're actually more accurately called an Achilles tendinosis. Same thing with the plantar fascia in the bottom of the foot. If it's more than a month old, it's really plantar fasciosis, right? But nobody knows what the heck that is, so even in my daily work, a lot of times I will use these terms just because people can identify with that a little bit better. But then I explain, well, this is not an inflammatory situation, it's more of this chronic situation, and here's what we can do about it. All right, so common injuries in the spine and the low back area. So looking at these diagrams here, so this is a bony model of the back half of the, not that I want everybody looking at my rear end, but basically this portion right here, all right? And you can see all these gray structures right in there. Those are the ligaments. So you can see that the pelvis, or the back of the pelvis and sacroiliac area, is just a big attachment site for these gray ligaments. And the red zones here, these is where the tendons attach. So it's just one huge attachment site for ligaments and tendons. And these are the names of some of the various ligaments and tendons that are frequently injured there. And the thing about ligaments and tendons is, you can injure a ligament, you can sprain a ligament anywhere in your body, just like you can in your ankle. If anybody's ever, kind of turned your ankle over, which of course I've done in some rather embarrassing situations back in my college days, which of course we won't get into. We just don't have time for that in this lecture. But anyway, if you can, sprain a ligament in your ankle, you can sprain a ligament in your low back too. So the process is the same. It's just a question of the mechanics and the forces that are involved, whether it's a car accident or a bad fall on the ice, of which unfortunately there's still plenty out there. So the mechanisms are just very similar. It's just depending on where is it located. Next slide, please. All right, so basically, these ligaments and tendons are everywhere. I showed just one example in the low back, but every joint area in the body, you have multiple ligaments and tendons. One particular area that I enjoy helping with is in the hip, because there's a lot of stuff that happens in the hip that classical orthopedics and musculoskeletal medicine, they just don't do a real good job of it. And part of that is because of how complex the anatomy is. You have something like 23 different tendons that cross the hip joint. You have 3 ligaments around the ball and socket joint itself. You have the capsule, you have bursae, you got all kinds of stuff in there. And so it's a very complex region. So to think that all of your pain is simply coming from arthritis or a labral tear, like one structure in this extraordinarily complex area, at least from a logical standpoint, it doesn't make a whole lot of sense. And so when you really start working with people and you do a good job asking them about their pain and really examining them, you'll find that in many of these cases of ligament and tendon injury, you have many more than just one structure that's injured. You might have, 4 or 5 structures that are injured, and you have to address all of those structures to really get people as close to 100% recovered as possible. So the other thing that's important to realize is that these tissues, they just don't heal well on their own, which I alluded to before. we actually have some studies, unfortunately, in the in the poor animal models looking at rats and rabbits and things like that, where they actually induced ligament and tendon injuries, and then they measured how well they healed naturally, and the best you can get is about 70 to 80%, and that's maximal. Many times because of lifestyle issues or mechanical issues or nutritional issues or other medical comorbidities, that number is less than 70 to 80%. And so you're stuck with this tissue that's been injured that partially heals but not fully. And then so it can eventually come back to haunt you in your, in your later years. Me, for example, I've got this left knee tendinosis, not tendinitis, but tendinosis that I had when I was 14 running cross country. And, I did some therapy, it went away, and it hasn't bothered me for like 20 years. And in the last couple of years, it's starting to creep back a little bit. So I need to actually, treat myself, which I've done. I know this is a little strange sounding, but I've actually treated myself with regenerative therapies. And let me tell you, sticking yourself with needles to heal damaged tendons is one of the more surreal experiences of my life, I must say. But, hey, the stuff works. So next slide, please. Okay, so what type of symptoms and signs do people exhibit when they have tendon and ligament dysfunction? So a lot of them have a history of trauma, but not everyone, right? So things like motor vehicle accidents or MVAs, whiplash injuries, falls, and so on. Pain upon awakening. So you wake up first thing in the morning and it's like, oh man, my back's really sore. Or yeah, that plantar fascia pain on my heel really feels pretty nasty when I wake up in the morning. And also after physical activity. So, for example, when I had my knee tendinopathy, when I was a runner, I would start running, and then it would hurt for like the first couple of minutes, and then the pain went away after I warmed up. Now I'm running, I feel great. And then I finish my 3-mile or 5-mile run, and then like 15 minutes later, after I cool down, then the knee starts aching, and then I was icing my knees down every day after training and that sort of thing. So that pain that comes in after you exercise, that's tendon-related pain oftentimes. Improvements that you may get from physical or manual therapies, so like physical therapy, chiropractic, osteopathic manual treatments, and so on, they either don't hold, like they last hours to days, or they can actually make the pain worse. And the reason they can make the pain worse is, let's say you have you've got a joint here, and you've got a ligament that's stabilizing that joint, and that ligament has been sprained, and that joint just doesn't quite have the stability that it used to, so it falls out of alignment. Well, you can get that joint back into alignment, but it just won't stay in alignment because the structures that keep it in alignment can't do their job right. And that's why these treatments either don't hold, or if it's more loosey-goosey, you just can't even ever really get it back into alignment, and then so the pain can actually get worse with manual therapies. Other things are if people have joint hypermobility. So people who say, oh yeah, my elbows are double jointed or something like that. It's not really double jointed, it's just that you have an excessive amount of flexibility in those joints, and that can actually predispose you to ligament and tendon injuries, and we're going to talk about that a little bit. Also, this is a really big one, the last point here. Referred pain, also known as pseudo-radicular symptoms. You could spend a whole lecture just talking about this, but basically what that means is that, okay, sciatica. Everybody hears the term sciatica. If I could go back in history and eliminate a word from the medical dictionary, it would be sciatica. Because sciatica means, by definition, that you have an injury to the sciatic nerve, and that sciatic nerve pain is causing this pain going down the back of the leg. Now, there has been some research looking at this, and a number of people that have true sciatica, like true sciatic nerve problems, is 1 in 250,000 people. So it's actually exceedingly rare. However, on a daily basis, I see people that have pain somewhere, and then it's radiating down the back of their leg, or somewhere around their leg. And I can tell you for a fact that many times it is not coming from a nerve. Now, in conventional medical training, we always talk about nerves. You got a pinched nerve in your low back, let's say like an S1 or an L5 or something like that, and it causes pain in a certain distribution. That is absolutely true. However, there are many other sources of pain that are not related to nerves that can cause pain in almost exactly the same distribution, and I'm going to show you a picture of that. So radicular pain is nerve-related pain. So people talk about radiculopathy from a pinched nerve. Pseudo-radicular pain means basically false nerve pain, and that's exactly what happens in these people that have this so-called sciatica going down the leg, but it's actually coming from a ligamentous problem in their sacroiliac region, for example. Next slide, please. Okay, so let's talk about this hypermobility thing. Yeah, that just looks painful. I don't think what is a picture's worth 1,000 words? I think the 1,000 words would basically be ouch, over and over again. But anyway, so how common is it? So there are some studies that indicate that between 4 and 13% of the general population have this joint hypermobility syndrome. It is much more common in women than men. I believe the ratio is something like 9 to 1, if I remember correctly. One study showed that in 66% of children with arthralgia, which is joint pain of unknown cause, that 66% of these kids had joint hypermobility syndrome. It's diagnosed by primary care physicians in only less than 10%. So it's something that isn't really on the radar of a lot of doctors, but we see it all the time. And let me tell you, it definitely contributes to this ligament and tendon pain. Next slide, please. All right, so when you diagnose this, there is this fun little exercise, if you will, that's called the Baton score. It is has a 9-point maximum. All right, so I'd like everybody to kind of do this with me. See, this is the point in my lecture where people start kind of getting that glazed over look, and so this will help hopefully wake people up just a little bit. All right, so basically there are 5 different tests. 4 of these tests are left and right, so you get 1 point each for left and right times 4, and then there's one more test that's another point, so it's a total of 9 points. Right? So if you kind of want to do this with me, it's up to you. But for one of the tests, and fortunately I am not hypermobile, so but basically if you take your finger and try to bend your pinky finger back, like hyperextend it, and if it hyperextends to more than 90 degrees or greater, that's 1 point. I've got 0, so I can't do it on either side. Right? Then the next one that I do is this one. Now this one I really stink at. I have wrist injuries from gymnastics, but basically you bend your wrist and then you take your other hand and you push on your thumb and see if you can touch your thumb to your forearm. And as you can see, I can't even get close here, so I'll break something if I try to do it. All right, so that's 1 point on each side there. Right? So the next one is the elbow. So if your elbow hyperextends more than 10 degrees, that's one that I actually do have. I don't know if you can tell here, but, yeah. So I've got it on both sides. So I've got 2 points. Something tells me I'm going to lose this game. All right, then the knee, same thing. So this shows it with the patient lying down, but basically if you stand, now this one you'd have to kind of stand up and have somebody look at you, but if you basically stand and you lock your knees back and you've got this backward curve of more than 10 degrees, that's 1 point on each side. All right? And then the last one is at any point in your life, not just now, but at any point in your life, if you've been able to bend forward like this, like you're touching your toes, and plant your hands flat on the ground. All right? And so that indicates excessive mobility in your hip and low back area. The reason why that you test that, I don't bother testing for it, I just ask the person, have you been able to do this? The reason that it is important if you could do it at any point in time is, let's say somebody comes in and they've got a back injury. Well, what happens is the hamstrings can be overly tight because they're trying to guard the hip and guard the low back. So you can't do that anymore because now your hamstrings are overly tight. It has nothing to do with joint hypermobility. That's just the fact that your muscles are tight because they're trying to protect a joint that is already hypermobile. So anyway, so that's 9 points. If you have greater than 4, that's considered a major criterion towards the diagnosis of hypermobility syndrome. So it's only one criterion. You actually have to have 2 major criteria or more to actually have the diagnosis. And I don't think I put the other diagnostic criteria on here because it's just this huge list of stuff. But anyway, this is one thing that people can do to kind of get a sense, okay, am I possibly hypermobile? And if so, could that be contributing to something that might be going on? So, all right, next slide, please. All right, so this is the thing I was talking about, the nerve or radicular pain versus the pseudo-nerve radicular or a sort of false nerve pain. Okay, so this side shows the distribution of pain when you have an actual pinched nerve. So if we take this sciatic, back of the leg pain, this is the back of the leg, this is the front of the leg, but that S1, I don't know if you can read it from where you are, but that says S1, S1. So kind of down, across the buttock, back of the thigh, back of the calf, down into the foot. That represents a classic S1 pinched nerve coming from your low back. Now, if we look on this side, here is the front of the leg, here's the back of the leg. This shows pain distribution coming from ligaments. Has nothing to do with nerves, but from those ligaments that are in your sacroiliac region. And you can see back of the thigh, back of the calf, outside of the foot, very similar to an S1 radiculopathy. So this is where people fall in this trap, where if they get that pain, they automatically think it's a nerve. They get the MRI. The MRI might show a little disc. protrusion that's not really mashing on the nerve, but you know what, you got a herniated disc, here, let's try this epidural. And you get the epidural, it doesn't work. Oh, well, it didn't work because, you know, the disc is causing too much of an injury, so you need surgery. And they go and they get the disc taken out, and guess what? Their pain gets no better, right? So this is a situation where it is very important to distinguish, is it nerve pain, or is it pain that looks like it's coming from a nerve, but it's actually from a ligament? And I've had, I don't know, hundreds, probably, thousands, I don't know, at least hundreds of patients now, even just with low back pain, that come in, they have this pseudo-radicular pattern, and I say, well, you know, on physical exam, your nerves seem to be working fine. You know, you don't have any numbness, you don't have any weakness, your reflexes are intact, so this might not be a nerve, and I don't have an MRI yet, but you know what? I have good physical exam information, and you know, and I've tested their ligaments, and hey, you know what? You got this pain that correlates with this exact ligament right here. Here, let me show you it in the anatomy book. What we can try is we can do a little injection in here, put some numbing medicine in that ligament, and if we numb up that ligament and your leg pain disappears, well, guess what? It's not a nerve, it's coming from your ligament. And that's exactly what I'll do if the person feels comfortable with that approach. We don't have to stick them in a big magnet to get an MRI. They don't have to get this epidural. They don't have to get x-rays. They don't have to get surgery. We just do that, and then if we isolate where their pain is coming from, boom, then we know how we can get them better, right? Next slide, please. So let's talk a little bit about healing. So how the heck do we heal? Well, if everything goes right, on a cellular basis, there are 3 phases to healing. You start with inflammation. Now, isn't that interesting? How many people out there have heard, oh, inflammation's a bad thing, it causes pain, and you want to take these anti-inflammatories to get rid of the pain? Well, the truth of it is that inflammation is the first phase of healing, and it is critical. Without inflammation, we would all not be alive right now because you would not be able to heal. So you sustain an injury on day 0 here, and then you go through inflammation, which lasts somewhere like 4 to 6 days. Then you have the second phase of proliferation. This is where you kind of get the scaffold of the new cells and the collagen fibers and all that stuff. And then maturation is phase 3. This thing can last actually out to about 1.5 years. So if you sustain an injury, let's say you sprain a ligament, most of your healing is going to happen really out to about the first like 3 months or so, which is that part is not shown on this graph. But anyway, so most of the healing occurs first 3 months. After that, it slows down a lot, but you still get some healing out to about 1.5 years. Pretty long process. So you can imagine that if you go in here and you sustain an injury and then you take a whole bunch of anti-inflammatories and you block that inflammation response, well, guess what? You're not going to heal as well. And so I always counsel my patients, if you sprain an ankle or you have some other injury, try not to take the anti-inflammatories for about 5 days. Wait until you get past this phase. Then if you still have a lot of pain and swelling and all that, then you can take your anti-inflammatories. Next slide, please. All right, so in terms of treatment, this is an overview of all the treatments, and we're going to talk about each one in great, exhaustive, nauseating detail. Actually, we're just going to focus on a couple of them. But you can see that, and this is just a partial list. There's all kinds of stuff that people are going to throw at you when you have these types of injuries. Next slide, please. So we are going to focus on the regenerative therapies for the sake of time and just, talking about cool stuff. So prolotherapy, platelet-rich plasma, autologous stem cells. Notice how I crossed out anti-inflammatories and corticosteroid injections. The reason is for the purposes of this particular lecture. Now, there are plenty of things that steroid injections, well, okay, that's not true. There are a few things that steroid injections are good for. Most of the stuff that steroid injections are used for, it actually is not good for you. And if you look at the research, that's what it shows, that at 3 months, you actually do better than the group that doesn't get steroid injections in terms of pain. But at 12 months, 24 months, there are some studies that show, a growing number of studies, that you actually do worse at 12 and 24 months compared to the group, for example, that just had therapeutic exercise. And the reason is that the reason steroid works for pain is because it reduces cell metabolism. When you reduce cell metabolism, you reduce inflammation, you reduce pain. With reduced pain, you can actually do more stuff for a while. But then if you reduce cell metabolism, guess what? You don't heal as well. So what happens a year, 2 years, 5, 10 years down the road? When you don't have as good healing, you're not going to do as well down the road. And that's what the research is showing. Okay, next slide, please. All right, so let's talk about prolotherapy. What the heck is it? So prolotherapy is short for proliferative therapy. And by definition, it is a method of injection treatment designed to stimulate healing. Various irritant solutions are injected into the ligaments, tendons, and joints to encourage repair of damaged tissue. So that is the basic core definition. Next slide, please. So it goes by a few other names. Regenerative injection therapy is kind of the modern, nifty term that people like to use. Sclerotherapy is what it used to be called back in the 1940s and 50s. Now, sclero actually means scar forming, and it is an obsolete term, and it is rather frustrating that there are still some experienced prolotherapy physicians out there that call it sclerotherapy, even though it's been proven since the 1950s and 60s that it doesn't cause scar tissue. It actually causes the healing of organized, normal collagen fibers. And that's been shown in a number of studies, both microscopically, as well as on a gross anatomy dissection, as well as on ultrasound imaging. All three of those modalities have shown that you actually get repair of regeneration of normal, healthy tissue. Some experts do consider platelet-rich plasma and stem cell therapies to be a subtype of prolotherapy, but most people will talk about PRP and stem cells as sort of separate from prolotherapy. It's all just kind of semantics. Next slide, please. So let's talk about a little bit of history of prolotherapy. So, most people have never heard of prolotherapy, so they think it's this, newfangled thing. But it's actually been around for over 75 years. Ligament-related pain was first related in 1930 when this dude named Laric injected numbing medicine into the ligaments and found that he got a lot of relief of pain. Then a few years later, Dr. Earl Gedney, who was an osteopathic physician, so I have a lot of pride with that as a DO myself. Anyway, back then it was still called sclerotherapy, so he used to treat the sacroiliac ligaments. So this is the first documented case of the use of prolotherapy for musculoskeletal injuries back in 1937. The term prolotherapy was coined back in the 1950s by Dr. George Hackett, the man right here. Next slide, please. And then there's been a lot of prolotherapy in the news over the years. Bodie Miller back in 2006, something about his performance in the Olympics, and there's a thing in the New York Times back in, 2007 or something. Next slide, please. Okay, so what are we injecting exactly? So the simplest solution, which is what I use on pretty much exclusively, is just high concentration dextrose, sugar water. Wow, that sounds crazy, because people talk about how a sugar pill is a placebo, right? Well, what's interesting is that there are several studies actually, that have shown that if you increase the sugar level by just 0.5% in the extracellular matrix around the cells, it actually stimulates those cells to release the same growth factors that activate the body's injury healing process. It's fascinating stuff. And so we use concentrations of 10 to 25%, which then gets diluted by the body's, with the water in the body tissues and things like that. But that's basically how you stimulate healing. And so here are just a couple examples of the ankle and the shoulder being injected. Next slide, please. All right, so then looking at platelet-rich plasma. All right, so we talked about prolotherapy, with dextrose being the main ingredient that most prolotherapy doctors use. Now we go to a little bit higher tech stuff with platelet-rich plasma. So this started up back in 1985. And so, what the heck is platelet-rich plasma? So actually, I thought I had maybe the slides a little bit later. But platelet-rich plasma basically is a process where instead of injecting a solution that stimulates your cells to release growth factors, we take your own growth factors from your own blood, we concentrate it, and then we re-inject it into the area of injury. So because we're taking your growth factors directly, it is more powerful than dextrose prolotherapy. It's about, by our experience, 2.5 to 3 times more powerful than the dextrose prolotherapy. It is more labor intensive. It involves, we have to draw up your own blood in order to concentrate those growth factors which are contained inside the platelets. And that's why it's called platelet rich, because by concentrating the platelets, you concentrate the growth factors, and you can really enhance your own healing. Anyhows, in the 2000s, there was a rapid increase in scientific research here. And then in 2009, the Pittsburgh Steelers, who won the Super Bowl that year, 2 of their star players had PRP done on them just weeks before the Super Bowl. And so I don't know if any of you know who this gentleman is. That's Hines Ward. I'm a big Steelers fan. I lived in Pittsburgh when I was a little kid. So anyhow, so next slide. Okay, here we are, sort of. All right, so basically, during the process of concentrating the platelets, we concentrate to on average, 4 to 7 times your normal platelet count. And this is the process right here. So number 1, we draw your blood. Number 2, we stick it in this little centrifuge, which spins it around and, all that kind of stuff to concentrate the platelets. Number 3, we prepare it by drawing it up into the syringe. and there's a little bit of a preparation process involved. And then number 4, the MD or DO applies the injection to the appropriate area of injury. So here's an example of injecting it into the elbow for a tennis elbow. Okay, next slide. So what happens is these are the platelets when they're not activated. So when people think about platelets, and maybe any of you that have taken like biology and that sort of thing, you see these little tiny things floating around in the blood, and they're a lot smaller than red blood cells and all that. Well, that's true when they're not activated. But when they activate, they turn into these monstrous-looking things, and they release all of these little growth factors, which are, this is a little cartoon indicated by these little white diamond thingies. But when that platelet activates, that's what helps with the clotting cascade. Like a lot of people know about platelets in terms of how they, are critical in blood clotting. Well, that's absolutely true. But in addition to clotting, they are responsible for triggering the healing process. And they do so by releasing all these growth factors. The same growth factors that we harness when we do a platelet-rich plasma treatment for your particular area of injury. Next slide, please. All right, so a lot of patients who come in and they know a little bit about prolotherapy and a little bit about PRP, they say, well, what's the difference? Which one's better? Which one is right for me? And so when you look at comparing the two, so your dextrose prolotherapy, you have very inexpensive solutions because it's just dextrose and some lidocaine and some normal saline, real simple stuff. It's not quite as powerful, but it has a pretty good effect on the ligaments in particular. You need more treatments because it's not as powerful, but you can use more volume during the treatment. You can treat a larger area. And it involves the use of very simple equipment. It can be done almost anywhere, namely Mexico and Honduras, where we do a lot of our work with just basic supplies. In contrast, PRP, it's a lot more expensive in terms of the materials because you need the centrifuge, you need the specialized kits, you got to draw the blood and all that kind of stuff. It is certainly more powerful, especially for joints like people that have late-stage arthritis. The PRP can heal things in ways that the dextrose prolotherapy cannot. So you have fewer treatments that are necessary, but you have a limited volume because since we're processing your own blood, the technology is limited in terms of how much PRP you can get in each one of these little kits that you have to use. It's more labor intensive because of the blood drawing and the processing. And one other advantage is that it is autologous. What does that mean? It means that it comes from your own cells. So when people talk about PRP being autologous or autologous stem cell therapy, that means that you're using your own cells. You're not using somebody else's cells. And so because of that, there's no chance for you to have an allergy because they're your own cells. Right? Next slide. All right, so let's talk about stem cells now. All right. We could spend a week talking about stem cells. There's a lot of evolving technology. There is controversy involved, both from a clinical standpoint, a scientific standpoint, and, frankly, from a medical legal standpoint. The FDA is still trying to figure out what to do about this stuff. But basically, the simplified idea of what stem cells involve is that growth factors that you get from prolotherapy and PRP, those are sort of like the commanders of the battle. They tell the cells what to do. The stem cells provide the actual workforce. So the stem cells are kind of like the soldiers, all right? Now, there is overlap there, because in PRP you do have some stem cells, and then stem cells do release some growth factors, and so you get some, overlap there. But the basic idea is that stem cells provide the actual force of cells that can go in there and actually do the healing if you have a situation where you don't have enough of your own cells in that area. Next slide, please. Okay, so as I mentioned, lots of controversies. There's a lot that isn't known yet. We know a fair amount in terms of musculoskeletal application. That's the thing. I mean, it's actually been used in musculoskeletal application for more than 10 years. So it's been around. And the research is definitely growing very rapidly, but there's still a lot of stuff that we need to know. So some of the things that we want to consider are adult versus embryonic. So all of the stuff focuses on adult stem cells. It was more than a decade ago, actually more like 20 years ago, I guess, where there was this whole controversy about using embryonic stem cells from just kind of like an ethical standpoint, and that's really not on the table at this point, at least not, in any kind of practical terms. Then you have these crazy words here, mesenchymal versus hematopoietic. So that just basically means what cell line does the stem cell come from. And the mesenchymal stem cell seems, at least according to current research, to be the one that really is useful for regenerative capability of things like bone and cartilage and heart tissue and stuff like that. Then you have the source of the stem cells in terms of bone marrow versus fat derived, in terms of where on a practical basis do we get these stem cells from. And so bone marrow seems to be the winner so far. It has more research behind it. The bone marrow's mesenchymal stem cells seem to have a much better ability to differentiate into actual cartilage cells and bone cells and ligament and tendon cells and that kind of thing. So for the purpose of what we're dealing with here, with ligament, tendon, and joint problems, the bone marrow really seems to be the powerful stuff. But we can also get a lot of good stem cells from fat tissue, right? And so the fat tissue helps to support the bone marrow stem cells in a lot of cases, and so sometimes you use one, sometimes you use both. There's a lot that is involved in selecting which type of stem cell therapy that you use. And this is just a little cartoon that shows how that mesenchymal stem cell can divide into bone, cartilage, muscle, skin, and soft tissue like ligament and tendon cells. Next slide, please. All right, so what are the pros and cons of stem cell therapy? So the pros are, it has the highest regenerative potential, shows a lot of promise. I've seen cases of people that had dead bone in their hip, and they had a couple of stem cell treatments, and it actually regrew the bone in their hip. It was pretty incredible. It is a potential treatment for more advanced degenerative conditions, so people with like end-stage arthritis and so on. And that is a situation where, as I kind of alluded to before, the body's own cells are either non-existent or they're just not functioning very well. So if you've got bone-on-bone arthritis where there's no cartilage left, you can put as much PRP in there as you want, but it doesn't have any cells that to work on because the cells are already gone. So if you put stem cells in there, well, those stem cells can basically replace the cells that you have lost. Then you activate it with the prolotherapy and the PRP, and the next thing you know, you're going to be growing cartilage. Now, this sort of thing is not going to give you a brand new joint, I don't think, but it has a very good potential for really regenerating stuff that no other technologies have at this current state in history. So, what are some of the cons? It's very expensive, right? One treatment session costs a few $1,000s. Probably on average around the country, it's probably going to cost you somewhere between like, I don't know, like $4,000 and $8,000, something like that, and that's an out-of-pocket expense. It's currently not covered by insurance. The preparation and delivery of the stem cells is a very involved process. There are certain aspects of the preparation that you have to pay a lot of attention to in order to keep those stem cells basically viable and alive, and so that it can do its optimal work. There are limited research studies to date, but that research is coming, so it's only going to be a matter of time before we have increasingly good evidence about how effective this stuff is. And then there's this whole government regulation thing. That area is quite complicated. What's interesting is the reality of it is that the FDA is actually being sued because they are claiming jurisdiction in an area where legally they actually do not have jurisdiction. So it's very interesting. What they're saying is the FDA, and this whole thing started about 5 years ago, the FDA was saying that your own cells are a medication, they're a drug, therefore we govern the use of your own cells, which doesn't really make a whole lot of sense, right? So then they said, wait, okay, it's not your cells in entirety, it's if your cells are manipulated more than minimal manipulation, and that's the phrase that they use. And then the question is, well, what's minimal manipulation? Well, guess who defines what minimal manipulation is? The FDA. So they were trying to basically set all of the rules of how the stem cells could be used, and they're your own cells. They're not a drug. That's ridiculous. So they're actually being sued in 4 independent lawsuits right now. I think the 2 of which have been settled, and the other 2 are still pending, and they basically lost the first 2. So it looks like the legal ability to truly use stem cells is the future is very, very bright for this. So it's just a waiting game, basically. All right, next slide. Okay, so let's talk a little bit about ultrasound, and we're going to have a live demo in just a little bit. So the idea, it's the same technology that we use to look at babies and things like that. So you use sound waves to visualize tissue. And it's been used in Europe for over 25 years for just musculoskeletal applications. So I have to admit the U.S. is a little bit behind the ball on this because the utility, the use of MRI, CT scan, it's so ingrained in the medical culture that, frankly, care providers don't really think about using ultrasound that much, except for abdominal and pelvic stuff, or like if you're looking for blood clots. There's certain things that we use ultrasound for, but in the musculoskeletal realm, it is actually extraordinarily helpful. But it doesn't it doesn't pay nearly as much as, in all honesty, as much as like an MRI or CT scan. So hospitals would, and this is a realistic thing, they would have a lot of trouble keeping their doors open if they did ultrasounds all the time instead of the better paying MRIs and CT scans. Now, don't get me wrong, CT scans and MRIs are absolutely critical for looking for certain things. But there are a lot of other things that you could learn a lot about just by using ultrasound, as we will demonstrate shortly. So the technology has improved very rapidly over the last 10 years. They've gone from these big machines that are as big as this lectern right here, and now you can see that we've got this little thing right here. And actually the newest version of that machine is actually a tablet. It's like less than 5 pounds. And it has the same processing power as that thing right over there. So the technology is really quite amazing. Next slide, please. All right, so this just gives a couple examples of what you see on the ultrasound. And these things, it's hard for these things to project very clearly, in this type of environment where it's kind of dark and all that, but hopefully you can see a little bit from the back of the room there. All right, so what we look for is a difference between bright areas and dark areas. When you're looking at a tendinopathy or tendinosis, you look for dark areas. So dark, what we call hypoechoic. If you see those areas within a brighter hyperechoic area, that tells you that there could be some injury there. So here we have a normal tendon, all right? So you can see that it runs along like that. Yeah, and so these two, they're a little bit hard to see in this light. But here, where those arrows are, there's a focal darkened area inside that tendon, and that's an area of tendinopathy, or maybe actually even a tendon tear. Here you can see a little bit more clearly that the tendon is thickened, all right? So, and it's got these little dark areas in it. So a thickened tendon is actually not a healthy tendon, which doesn't make a whole lot of common sense. It doesn't seem to be logical because you think, well, if a tendon is thick, doesn't that mean it's strong? Well, one analogy is if you take a piece of twine, right? So twine, you kind of wind it down, you tighten it, and it's kind of got this little sort of like a spiral to it, right? Well, if that thing starts to become unraveled, it actually sort of gets thicker, if you will, because the fibers, they're not tightly packed anymore. Now they're just sort of loosey-goosey. And so the overall twine is now thicker, but it has less density, and it's actually weaker, even though it's thicker. And it's exactly the same case with the injured tendon here. This shows an MRI of, it's actually rotated 90 degrees, so like up and down is this way as opposed to left and right here. But it shows the bright signal that you get with an Achilles tendinopathy here and right in there. So you can correlate what you see on an ultrasound with what you see on an MRI. Next slide, please. All right, so this is an example of how you can use ultrasound to guide an injection. So hopefully you can see this from the back, but this is an elbow, and there is a bone spur right there. And you can use the ultrasound and actually guide the needle coming in, so you can see the needle right there and get the needle to exactly where it needs to go to treat that area of injury. The accuracy of these injections is approximately 0.2 millimeters. So it is very, very accurate. The resolution of the ultrasound is about 0.1 millimeters. And to give you an idea of how nerdy I am, I've been wanting to do this for like years, is to take a hair and look at it under an ultrasound and take a needle and see if I can cut the hair with a needle, and then I can say I can literally split hairs with this thing, right? But I haven't done that yet, so maybe I'll do it tomorrow, who knows. Anyway, I don't know if you can see the name from the back, but this is actually my elbow. So I have this pretty significant elbow tendinopathy from years of gymnastics and all that. And this is one of the first time, yes, this is the first time where I actually treated myself, and it was quite an interesting situation where I had my, because I was treating my own arm, my physical therapist was holding the ultrasound probe, and then I'm right-handed, and this was, I believe, my right elbow, actually. So I had my non-dominant hand, and I'm sticking the needle in myself, telling my PT, okay, move a little bit over to the right, okay, hold it right there, okay. And I'm sitting here needling myself, and we got some nice pictures. So anyhow, next slide, please. Okay, so what are the pros of using musculoskeletal ultrasound? We discussed just a little bit of this already. So you have it is the modality of choice for many soft tissue problems like ligaments, tendons, muscle, that sort of thing. Has a superior resolution to MRI. Yeah, MRI actually has a resolution of about 0.3 millimeters in terms of the standard MRI. There's newer high-tech, high-resolution MRIs that have a little better resolution. There's no radiation. You can examine a joint or any body area while it's under motion. So for example, that's real common in the shoulder. If you have like shoulder impingement, you can actually look at the shoulder and have a move, and then you can actually see the structure, the rotator cuff, getting pinched in a lot of cases. And you can use it to guide treatment, just as I showed on that previous slide. It is relatively very inexpensive in terms of overall cost. The cons are that you cannot penetrate through bone. So if I want to look inside of your knee joint to see the inner part of the meniscus, I can't do that with an ultrasound. I need to use most likely an MRI. All right. There is a significant learning curve in learning how to use this. It took me 4 months before I could even consistently figure out which way was up and down and left and right, and okay, this tissue looks good, this tissue looks not so good. So it takes a long time to get good at using this. And it is very operator dependent. If you change the angle 3 degrees when you're looking at a structure, it significantly changes the appearance of what you're looking at. So you have to be very, very conscientious of how you use this thing, and actually you have to have a hand that's at least as steady as a good surgeon. Now, fortunately, if you don't have a steady hand, you're not going to run into problems like you would run into if you have a surgeon that didn't have a steady hand, because you're not cutting anything. But nevertheless, you really have to have a very steady hand to make minute movements to really get the best angle to know exactly what you're looking at. Yes, which is that whole thing. The image angle is very sensitive. All right, next slide, please. Okay, so I'm not going to spend much time here, but in terms of the research, one of my frustrations, and any of you who have talked to any other doctors about regenerative therapies, in particular prolotherapy, a lot of times doctors will say some interesting things. They'll say, oh, there's no research backing that, or they say, oh, that stuff doesn't work, it's voodoo, or there's no evidence that it works for X, Y, and Z. Now, granted, we need a lot more research. That's absolutely clear. But we need a lot more research for the vast majority of things that we do in medicine. Having said that, there are over 100 randomized and non-randomized controlled trials, case reports, and case series for the use of, I think this is just prolotherapy actually, in musculoskeletal pain. There's a huge number for the platelet-rich plasma in terms of the number of studies that are coming out. About 90% of the current research that's coming out on regenerative therapies for musculoskeletal medicine is PRP, because frankly that's where the money is. There are device manufacturers that can sponsor some of these studies. There's money to be made. Nobody's going to pay for, a $5 million study that uses sugar water. Well, almost nobody. The NIH has funded a few studies, and they're continuing to fund some studies. But it's just hard to get good research because you got to get the money, Anyway, there are over a dozen systematic reviews with some of the citations here. So there's a pretty good amount of research that's out there. Next slide, please. These are all of the conditions that have been looked at from a research standpoint. So we've got a fair number of conditions, including your tennis and golfer's elbow, jumper's knee, your Achilles tendinopathy, plantar fasciitis that we talked about, rotator cuff stuff. Joint-wise, you've got hips, fingers, knees, ankles, jaw, and then in the spine, you've got these conditions here. So, and this list is continues to expand as the research comes out. So there's some pretty good stuff out there. If you get on PubMed and you do a search for regenerative medicine, for prolotherapy or platelet-rich plasma, you'll get quite a few hits. So kind of neat stuff. All right, next slide. One particular study that I want to draw your attention to is one that was published in 2008 by my friend Brad Fullerton. He's down in Austin, Texas. And he is a master with the ultrasound, the diagnostic ultrasound here. But what he did was he wanted to see, well, can we get people better even without using the ultrasound to guide the treatment? So he used dextrose prolotherapy, and he treated 3 different types of tissue all in the knee. He treated a tendon, he treated a ligament, and he treated the meniscus. And he did it all with classical prolotherapy technique that does not require image guidance. It just requires a very good detailed physical exam and good knowledge of anatomy, which is what I train all these doctors to do when I'm down in Honduras and Mexico. I've trained, something like 350 doctors now, I think, in how to perform this therapy. And he used the ultrasound only diagnostically. So in this example with the meniscus here, medial meniscus and MCL, hopefully you can see where you are in the back, but this triangular structure is the meniscus here. And there is this tear right there where it's just black, right? And then here you have some white stuff. That's healthier meniscal tissue. You can see the dates here. So he did 3 treatments at various time periods, I think like 2 or 3 months in between. And then he did serial ultrasounds as he went along. And it is really hard to see this with this projector, but here you've got obvious tear, and then by the time you get down to July of 2004, from December 2003 to July of 2004, it is pretty much gone. And so he demonstrated healing of these tissues, including meniscal tears, which usually you go and you get surgery done on these things, right? Well, heck, you can just stick some dextrose in there, even without image guidance if you have good technique, and guess what? there's a good chance that it's going to heal that injury. It doesn't work for everybody. It doesn't work for all conditions. It doesn't even work for, here it could work for one meniscus and maybe not work for another, but nevertheless the evidence is mounting, and it's pretty good to show that this stuff really does heal tissue. Actually, it gets you to heal your own tissue, really is what it does. Next slide, please. Okay, so the conclusion, this is a little bit of a busy slide, but just to go over the main points. So joint, tendon, and ligament pain or dysfunctions are common, and they are significant contributors to musculoskeletal pain. These dysfunctions can mimic other conditions, like the pinched nerve or that pseudoradicular pain that we were talking about. And so you have to be careful to differentiate that from things like nerve injuries. Joint hypermobility syndrome is easily diagnosable based on, just basically bending a few things and asking a few questions. And it is a risk factor for developing tendon and ligament dysfunction, so it's an important thing to ask about. Current science is focusing on the role of growth factors and stem cells in the cellular healing response, so there's going to be a lot more of that coming down the pipe. The effectiveness of historically accepted treatments, such as anti-inflammatories, steroid injections, the effectiveness is not well supported by the existing clinical evidence. And novel treatments such as prolotherapy, platelet-rich plasma, and autologous stem cell injections, with or without ultrasound guidance, show a lot of promise, and there are a growing number of clinical studies that are backing that up. All right, next slide, please. All right, so now that we've come full circle, and that's another, picture worth 1,000 words of ouch there. Anyway. It almost looks like some kind of strange Picasso-esque kind of artwork there. So that is the main lecture portion. Now what I'd like to do is have a little bit of time for questions and then a time for a live demonstration of the ultrasound. And maybe what we can do is while we're setting the ultrasound up, maybe I can field a few questions, something like that. So yes, there in the back.
Yeah, you had mentioned cartilage, its application in cartilage for, I'm trying to get this right, I think it's articular cartilage behind the kneecap.
Okay.
Which has the blood supply and therefore doesn't go well, right? In a case like that, what has been learned or is, I guess, thought of these therapies and the applications of cartilage?
So the question is in the role of articular cartilage, particularly, say, behind the kneecap, what do we know or what is the role of these type of regenerative therapies in treating that type of degeneration or disorder? Does that sound about right?
More succinct thing.
Yeah, okay. So there actually has been, there have been a couple of studies that were just published, I think, last year that have looked at this. The main thing to emphasize is that just because you have cartilage degeneration does not automatically mean that that joint is in trouble. As we were alluding to before, the fact that the majority of people that have articular degeneration really have no symptoms. Having said that, there is a study, quite a sophisticated study that was done in Argentina, where they had two groups of patients, and they did arthroscopy and MRI. Everybody had knee arthritis, and in one group they did prolotherapy, and in the other group they did not. And the reason that it was done in Argentina is that the research groups, the research review boards in the U.S. do not allow studies like this to occur, where they actually did arthroscopy on patients that did not receive treatment. So it was sort of like just a diagnostic arthroscopy. You can't get away with that in the U.S. You have to have some type of treatment with it. And what they found in that study is that just using dextrose, you actually do get budding of the healthy, the high-quality hyaline cartilage that makes up articular cartilage. There's actually two main types of cartilage. You have fibrocartilage and hyaline cartilage. Hyaline is the good stuff. And sure enough, the studies do show that you start to get budding of actual hyaline cartilage. Now, the studies went out to, I think it was 12-month follow-up, and it did not show enough growth to really, give you a full layer of cartilage. It didn't do it to that degree. But you figure, well, if just dextrose can actually get the good stuff to start growing back, then, what's going to happen with the PRP? What's going to happen with the stem cells? And there are studies that are currently underway that are looking at that sort of thing. Let's see, the second study, oh, gosh, you know what? I have to admit I'm blanking a little bit on the details to that, but anyhow, there are other studies that did show no significant change, at least on MRI, of the thickness and quality of cartilage, even though they had significant improvement in their symptoms. And that's the kind of confusing thing as well. How important is the cartilage? We're still trying to figure that out. So we don't have all the answers yet. Yes, in the green.
What are the effects of having a relatively large number of injections into
So the question is, what are the potential, primarily adverse effects of doing multiple injections into a joint? That is a good question. There are two things to consider. And I have this conversation with my patients when I talk about the pros and cons and the risks and benefits of these therapies. There are potential adverse effects from the ingredients of what we use, whether it's dextrose or the PRP or steroid or whatever. That's one piece. Then there are the adverse effects that occur from the actual injection technique. So it's two separate things, but both of them are very relevant when you do a procedure. Most of the adverse stuff that happens, frankly, is because of the needle technique. So for example, if I go in with a larger needle and I shear up against the cartilage, could I technically shear a piece of the cartilage off? I have a colleague who has observed numerous orthopedic surgeries, and sure enough, in patients that have gotten multiple injections into the knees, in some of these patients, you actually see these tracks in the cartilage when they open the knee up to do the knee replacement, and you can see that wherever the needle went in, it actually did shear up against the cartilage and cause some permanent marking, if you will, in the cartilage. Is that going to accelerate the damage or worsen symptoms? Honestly, we don't know the answer to that. So most of this stuff probably occurs just from the actual needle trauma. Now, in terms of the ingredients that are injected, there are so with the regenerative stuff, we don't have any data to suggest that there are any long-term negative effects at all. There is actually one study where they looked at injecting dextrose into healthy tissue and looked at the cellular response of that healthy tissue, and they found that the injections actually do not harm healthy tissue. So even if you miss the injured target and you inject it into a healthy ligament, at least according to that cellular study that we have, it's not going to cause any problems. Now, we know from our, combined probably hundreds of years of experience that if you inject structures that aren't symptomatic, they seem to do fine. Now, having said that, can you hit a nerve? Absolutely. Can you hit a blood vessel? Yeah, that happens. Is there a 1 in 20,000 chance of infection? Yes. I know of one colleague that has had one case of infection from a PRP injection into the knee. Can you injure organs? It's possible. The rates are a fraction of a percent, but there are recorded cases of lung injuries and things like that when you're working around the ribs and so on. So yeah, these things can all happen. They're not unique to the regenerative therapies. They can happen with any kind of injection therapy, frankly, in terms of those needle complications. One thing that can happen is you can get a flaring, like people that have this, actually I'm very glad that Dr. Gary brought up the whole situation of kind of having this neuroinflammatory situation, that can affect the entire body. And we see in those patients, a classic example is people that have Lyme disease. They have this kind of pro-inflammatory, painful condition through their whole body. Well, if you treat them with too strong of a regenerative solution, it'll flare them pretty badly. It doesn't hurt anything, and they still get better. They still have a regenerative response, but they're pretty miserable for a couple of weeks afterward because you're getting such a strong healing response and that inflammatory cascade that it can cause a lot of pain. So we see that from time to time. Fortunately, I've done enough of this that I've gotten pretty good at identifying who those people may be. And we can tailor it where we reduce the concentration, we add a couple of other ingredients to help quiet down the potential for having that kind of pro-inflammatory response. And I use the smallest needles possible. That's the thing. The more I've done this, the smaller and smaller I get with the needles because it hurts less, fewer chances of complications. It takes more skill to use a smaller needle because it's flexible and it's harder to get it where you want. That's why it took me 5 years before I started using the little 27 gauge needles. But whereas some folks that do prolotherapy will use spinal needles all the time and these big harpoon-esque needles that look really scary, I pretty much never use those now. So especially when I have the ultrasound, frankly. So let's take maybe one or two more questions and then we'll do the demo. Yes, in the gray.
Does the use of blood thinner have any indication on PRP or any of the other prolotherapy?
So the question is, does the use of blood thinners affect our decision, I guess, to do the regenerative therapies? So the blood thinners, except for, other than aspirin, the other blood thinners do not seem to have an effect on how effective the regenerative therapies are. Aspirin can mess a little bit with platelet aggregation, so there's a question of whether using aspirin can have a negative impact on the effectiveness of PRP. That has not been studied in isolation, so I can't say yes or no. I would say that if you have a choice of stopping the aspirin for a few days beforehand, then that would probably be a better idea. However, blood thinners can affect your decision to do any kind of injection therapy, whether it's steroid or prolotherapy or PRP or whatever, just because of the trauma from the needling. And so, for example, if I'm going to inject around the spine, then I don't have people go off all of their their blood thinners for a few days, if of course it's medically safe to do so. But then there are plenty of other times where, let's say, I'm going to inject their elbow and they're on Coumadin, and I'm using a tiny little 27 gauge needle with ultrasound guidance. You don't have to have them stop. In fact, there are data to show that increased bleeding in the area actually helps with the healing process. So as long as you don't hit an artery or something like that, then it's fine. Next question. Last one. Yes, in the red.
I have a question about technique. You talked exclusively about using ultrasound to guide. What are your thoughts about the fluoroscopic microscope?
Okay, so the question is use of image guidance. I talk about ultrasound, but also there's a question of using fluoroscopy. So fluoroscopy, also known as a C-arm, is basically a live X-ray machine. It looks like a C, and so the table is like this, and then the C goes like that, and then it projects a beam through the table, and it's used very, very commonly for spine procedures, things like epidurals and nerve root blocks. They'll use it for hip injections, that kind of thing. So that's a very interesting question, actually, and one that we talk about a lot. Fluoroscopy has unique capability to do things like epidural. Well, actually, you know what? That's not true. It's not really unique. You can do it with ultrasound, but it's a lot harder. But in terms of doing the epidurals and nerve root blocks, it's just you can get a more clear picture using the fluoroscopy. You do have exposure to radiation. It's a lot more expensive. You have to have a specialized facility with lead-lined walls and all that kind of stuff. And so there are limitations for using it. Most of the stuff that you do with fluoroscopy, you can do with ultrasound, and there are probably hundreds of applications that you can use with the ultrasound that you cannot do with the fluoroscopy. Because with fluoroscopy or X-ray, you can't really see soft tissue very well. So if I've got a 0.5 millimeter tissue defect in the rotator cuff that I can see clear as day on the ultrasound, there is no way you can see that on fluoroscopy. So there are advantages and disadvantages to both. All right, so why don't we do a little live demo here. Basic orientation here is that when you're looking at the screen, John's skin surface is here. And then his head, his head is kind of up in this direction, and his feet are kind of down in that direction. So it's as if his leg is going across the screen that way. The hardest thing for ultrasound is orientation, figuring out which way's left, which way's right, and all that kind of stuff. All right, so to orient, one of the easiest landmarks is the kneecap right here, the patella. All right, so this is the upper part of his kneecap right here. And then if I go up even further up his leg, then this is actually the surface of his thigh bone right here. This is the femur. All right. So we got the femur coming down, and then boom, you got the kneecap. Now, as you can tell from what I was saying before, that the ultrasound does not penetrate through bone. So you can see how we can't really see beneath the bright line here. Like all of this is basically nothing, all right, because the sound waves just bounce right off the bony surface. Darken it just a little. All right. So here is one particular tendon right there, the quadriceps tendon. So you got the quadriceps that come down here. You can see the quad tendon tissue right in here, these bright parallel lines like right there. That's real nice tendon tissue right there. And then it comes down and inserts right at the top of the kneecap. You might be able to appreciate that this is darker than that. So that is not totally healthy tendon tissue. It's not bad, but it's not perfect. So then we continue down, and we're on the surface of the kneecap here, and because the kneecap is very superficial, we can't see anything underneath it, right? I don't know if you can see the scale over here, but this gives you a scale of the actual size. So each one of these tiny little blue tick marks is 1 millimeter, and then each one of these big ones is 1 centimeter. So if I zoom in on this, so this is kind of like the maximum zoom here. So on that screen, 1 millimeter is now about, I don't know, what is that distance? That's probably like an inch maybe on the screen or something like that. So you get a magnification factor of about 20 to 1 when you're looking at that screen. So things on that screen are going to look huge even though they're actually really tiny. So now we go down to the bottom part of the kneecap, and in this here is the patellar tendon. So this is where you get jumper's knee. People, athletes and stuff that get jumper's knee, they get it right here most of the time. So it's right on the insertion of the knee right there. And John actually, he's got a bone spur right here. Okay, so you can see how in this portion of the kneecap it looks relatively smooth. But if I move over to his right, whoa, now we got that right there. So that's a bone spur that represents that the basically it's a long-term chronic amount of increased tension of the patellar tendon as it kind of tugs at the bony attachment there, and that's where you get the bone spur. Now, the nice thing about the ultrasound is you can also look at these things in multiple planes. So now I'm going to rotate this thing 90 degrees, and we're going to look at this bone spur in sort of like a cross-sectional view. All right, so here we go. And there it is right there. All right, so here's the kneecap. So now we've changed our orientation so that, oh, actually, let me go this way. All right, we've changed our orientation so that John's left side is over here and his right side is over there. So it's as if I'm looking at him right here. It's the same thing. So his left is here, and on the screen, it's on that side. His right side is over there, and on the screen, it's on that side. So now we're looking at left, right here. Here's his kneecap in cross-section, and as I move upward, you can see, well, there's that bone spur again in this direction, right? And a lot of times in this particular tissue, you get almost like this sort of thing that looks like a comb, like the teeth of a comb. That's a very common appearance of bone spurs in this area, and he's actually got a fairly, you can't really call it, it's like medium-sized, but even a medium-sized bone spur there, like that thing right there is about 2 millimeters high and about 5 millimeters across. So that's pretty small. But in bone spur, ultrasound measures, it's pretty big. So,
How would you treat it?
well, a lot of times you don't have to actually. But truth be told, if you have a symptomatic bone spur there and you treat the tendons around it and you repair the tendons with regenerative therapies, but they're still symptomatic, you can do what's called a needle tenotomy, and you basically go in there. This is where you do have to use a bigger needle. And the question was, how do you treat it, by the way? And so what you do is you numb that area up, you take a bigger needle, and you just basically jab that thing, and you break it up into pieces, and then it eventually gets reabsorbed by your body, and it goes away. So it doesn't always work with like the big, the big bone spurs that have been around for a long time. But see, bone spurs are not always solid calcification. A lot of times, if they're like a tendon calcification, it's more like toothpaste. It has like a toothpaste consistency, and so you can break that up very easily. And then you come back and you scan it a couple months later, and guess what? It's gone, and their pain is much better. All right, so now let's take a look at the inner edge of his knee and look at his meniscus. So here we've got the going back to like the north-south view. So his head is up here, his feet are down there. And then here's his kneecap again. Now we're going to swing to the inside edge. Okay, now here is his thigh bone. And then if I move downward, here is his shin bone. And this is his joint line right here between the two bones. And this is where his meniscus is right there. So let me take a look at this. All right, so he's got a little bit of what we call a meniscal extrusion, where the meniscus is pouching out a little bit, so it looks almost like a little ice cream cone right there. It might be a little hard to appreciate on the screen there. But a totally healthy meniscus is flat and flush with the surface of the bone. I don't see too many of those, as you can imagine. Most of the time, people have a little bit of an extrusion like that. You can get fluid in here. You can get calcifications. You can get tears. You can a lot of times see like these, he might have just the tiniest little bit of a tear right there, but you can see, all kinds of stuff in here. Now, one thing you have to keep in mind, as I mentioned before, is that you cannot penetrate. John's being a great sport. I really appreciate this. But you cannot penetrate inside the bone, so you can only see about 10 to 15% of the entire meniscus here. So it's rather limited. All the rest of the meniscus is down in here. I can't see that with ultrasound. I have to get an MRI to see that. But you get secondary signs of meniscal tear, such as the meniscal extrusion. So even if the meniscal tear is down here and I can't see it, if the person has an extrusion, that's a pretty darn good sign that they have had a meniscal tear, even if I can't see the exact location of that meniscal tear. So the other thing you can see is that the joint space is narrow, because since I've done so many of these, you just know what these things look like. And so I know that the average distance between the two bones is about twice of what we see here. And so when you get more advanced arthritis, you lose the cartilage and the joint space gets more narrow. And so that's what we're seeing here, is that there's a little bit of joint space narrowing, actually a moderate amount of joint space narrowing there. Now the good news is that he doesn't have the typical like bone spurs that you get with arthritic knees and, well, arthritic joints in general, where you get this big buildup of bone over here and this big buildup of bone over here. This is one of the smoother joint surfaces that I've seen in a while in someone that has this degree of joint space narrowing. So that actually is real. What it means is that your arthritis is not, it doesn't have a chronic inflammatory irritation that's going on. If you had a chronic irritation going on, this is a pretty good view of the meniscus right there, but if you had a chronic irritation going on, you would get bony buildup along this area, and that's where you get some of these arthritic bone spurs, and you don't have that. So that's a nice thing. So you can use the ultrasound to look at these things, and you can get diagnostic information, you can get prognostic information, you can guide your treatments, and all of that stuff. So I guess we'll kind of wrap up the official portion here.
David, truly, truly outstanding. Thank you. 5 years ago, I had been doing some prolo, but my wife had injured her hip, and the surgeon, the orthopedic surgeon, take a look at it and says, well, it needs to be replaced. And we said, well, how about doing prolotherapy on it? And the orthopedic surgeon says, that won't work. I said, well, as opposed to replacing her hip, how about if we try it? And I brought him a bunch of papers, and he said, well, you know, go do what you want. And at the time, David was still up at Harvard, and we started flying Fran back and forth to Spalding in order to get treated. And we're 5 years later, and she's still walking around just fine, thank you very much, with no thoughts of replacing her hip. The stuff works. This stuff makes a huge difference in people's lives. And you know, we're very fortunate to have David there, and I've had the pleasure of going down to Honduras and doing training myself for the last couple of years. So it's a piece of the puzzle. It's a very important piece of the puzzle, and really getting an understanding of where the pain is and what's generating the pain.